Our next session is going to be moderated by one of our very own at Contexture. The session title is Improving Outcomes, Driving Value, Using HIE Data and Value-Based Payment and Electronic Clinical Quality Measures. So Lauren Girard is our Vice President of Business Line Management at Contexture, and I'm going to turn it over to her to introduce the panelists and get the session started. Thank you.
I have a wonderful panel. I think the last session really teed up the conversation that we're going to have today around value-based payment and where healthcare is headed and how Contexture can really help to serve our participants in succeeding in that model. So we're going to talk through what is value-based payment, where are we going, how does that all play into population health, data utilization, how are we actually going to get away from that data in, data out, and really move into how do we actually utilize this data to improve healthcare and understand the challenges and pain points that come along with that and what we can do to help serve our participants. So value-based payment is really rewarding. So it's that carrot of being able to help participants serve their patients, working towards improving outcomes of care for that individual. So I'm going to talk differently. So in the past, historically, we've heard about the triple aim. So triple aim, improving patient outcomes, improving patient satisfaction, reducing total cost of care. Then that evolved into the quadruple aim. So how do we incorporate provider satisfaction? More recently, what we're seeing is the quintuple aim. And that's really starting to get at that equity inclusivity. So I'm really proud to not only oversee the quality programs, but the social determinants of health and how those all interplay. So some examples that we're going to focus on today of different programs that us at Contexture are supporting participants with day in and day out of our everyday work. So Quality Payment Program, QPP, historically that was meaningful use in PQRS. So I also have acronym soup up here today. So I will try to keep that to a minimum. But Quality Payment Program really brought in those quality measures, the claims-based or cost measures, and then also their improvement activities, which historically PCMH models, and then promoting interoperability, which were the historic meaningful use measures. We also see several alternative payment models, so that's going to include some of the work we're doing with Colorado Medicaid. We have Primary Care First model, which has now come following Comprehensive Primary Care Initiative. It's a very risk-based model for Medicare, and we have about 150 plus different participant sites working on that throughout Colorado, and we'll be supporting those practices in utilizing health information exchange data and notifications in and out of emergency rooms and hospitals. Just talking briefly, we mentioned earlier today the Differential Adjusted Payment Program is a DAP program in Arizona, and that program is really looking at the data quality coming into the health information exchange and a lot of the core work that we do with ECQMs. And with that program, are you sending in ethnicity data? Are you sending in discharge diagnosis? And how well are you doing those things? And so it really starts to say, we want even better data than what we're receiving today, and how do we get that to improve the outcomes of patient care? We also have Target Investment, which is newly funded in Arizona for the 2.0 program. So we're really excited to get involved in that, but again, focusing on improving healthcare, and there's a lot of equity and inclusivity milestones incorporated within that program. And then the last program I'll touch on is just the Hospital Transformation Program. So, beginning to support those notifications, how do we actually implement those things? How do we improve that patient care? And then other ways this might show up is in contracts, so accountable care organizations or ACOs, and commercial contracts. So I already touched on this, talking about the quality payment program, but we see the quality of care measures. And so those can come in the form of electronic clinical quality measures. They could come in the form of claims measures or HEDIS. Then we see that utilization data. So what is that cost of care? Looking at different milestone activities. Are you using the PDMP? Are you impaneling your patients at the primary care level? Are you forming a quality improvement team and making efforts to improve a focused measure or a different process? We heard this morning from Dr. Medlock, how do we improve that third next available appointment? That's going back into PCMH, and it's wonderful to see that moving into the behavioral health, where we've traditionally seen that in primary care. And the last component is we see a lot of more and more importance on risk coding. So how sick are our patients? So knowing our sickest patients are going to cost the most, but what can we do to make sure that the payers know how sick they are? They're not showing up in our waiting rooms. They're not showing up to see how sick they are. So we need to make sure that we're presenting the right documentation at the right time. Looking at some of the work on the Medicaid APM program. So this is where Creo Contexture has really focused on electronic clinical quality measures and working with HICPUF to be able to support practices. So through the APM program, Contexture is working with over 300 different clinics, and over 200 of them are working towards what we would call electronic reporting. We still have the manual option, and those are for participants who either don't want to participate and receive the technical assistance from our team, or their vendors aren't necessarily willing to participate in the health information exchange. And we're still looking at really creative ideas to be able to help them and give them that support that they really do want. And so what we're doing is receiving continuity of care documents from the different participants, and then we're providing out those performance measures. Not only are we just handing over the data, but we're also saying, how do we improve this? So we're giving that technical assistance. Now, what we hear all the time is, well, I'm performing really well. So what we do is we root cause. Is it a problem with, maybe it's a bug within the measure. So we're taking the time to make sure that any data that you're receiving is going to be validated. So maybe that's not the problem. So we've crossed off the bug. Second, we're going to talk about maybe it's an EHR documentation issue. So you are putting it in your EHR, but for whatever reason, it didn't make it to the continuity of care document. We work with you and your EHR to be able to submit that and make sure that we're making changes within that system so that they are flowing over to continuity of care without making a huge impact on your workflow. And then the last piece is maybe it's just a process improvement. Maybe we actually need to change what we're doing in our clinic by giving the depression screening up front. Maybe we didn't know that the body mass index measure required a follow-up component and how and where to document that component. So we'll work with practices on any of those three things to make sure that we're seeing outcomes like this childhood immunization, where in this case, you know, they were connected with CIS. And so through the immunization registry, that data showing up in their EHR, but they weren't actually hitting the reconcile button. And so by being able to teach them how to hit that reconcile button, we saw these improvements. Similarly with controlling high blood pressure, not documenting that second blood pressure that they always did when they saw high blood pressure patients. And so really just working with them on that actual process. And then depression screening. A lot of this came into coding. They were doing it, it wasn't counting because we weren't seeing the positive or negative flow through on the other side. So our team is working with patients, or with clinics and hospitals, working on how do they actually improve utilization of that health information exchange. How are you interacting with the portal? How are you using your notifications? We also have our qualified registries. So if you're looking to report for the quality payment program, again, if you're sending your continuity of care documents, we can easily get you connected, help and provide that technical assistance to get you to the other side and really successfully report in the quality payment program or in primary care first. And then we have consulting services on top of the many different programs that we support, but we have coaching. You know, what are the ins and outs of the quality payment program? They're increasingly complex, and at the participant level, we know that you don't have the time to be a subject matter expert in that. Being able to improve just quality improvement coaching, risk coding, and then we also have ECQM support if you're outside of quality payment program or Medicaid APM, but you need data for maybe your RAE, maybe you need data for your ACO. So joining me today, I have Audrey with us, and she is the Director of Program Operations at San Luis Valley Health in Alamosa, Colorado. She oversees all initiatives and services related to population health, community development, and transitions of care. This includes work with quality-based based payment initiatives. Additionally, Audrey teaches for the University of Denver Graduate School of Social Work, primarily for their integrated healthcare track. We also have Rich Lane joining us today, and he is the practice manager at Champions Medical. He is a family care medical clinic providing healthcare to patients ranging from infants to geriatrics. They've been operating at the same location for the past 12 years in Pueblo, Colorado, and have 2 nurse practitioners and staff of 11 people at the clinic. And finally, we have Dr. Tiffany Mahaso, and in her current position as Director of Practice Management of the Rocky Vista Health Center, Tiffany exhibits extensive clinical and administrative experience garnered with working with over 54 resident physicians every year at Rocky Vista Health Center. Dr. Mahaso is excited to investigate ways to increase patient volume, satisfaction, and improve the flow so that it's mutually beneficial to the staff and the patients. So thank you for joining us today. We're very excited. Audrey, do you want to share a bit about San Luis Valley Health?
Thanks for having me. Good afternoon, everybody. I know we're in the after lunch time, so hopefully I can pique your interest in some of what we're doing down in the San Luis Valley. So I have the pleasure of serving all 6 counties of the San Luis Valley, and if you're familiar with that part of our state, we are surrounded by mountains in every single direction. We're both considered rural and frontier, and we are a multi-specialty primary care integrated hospital critical access rural health system. So we are very intentional in our strategy of providing so many robust services under one roof, if you will, because we know that based on our geography, yet alone the other social determinants of health that our community faces, it's on us. We really have to make sure that we're providing as much as we can, as comprehensively as we can, to reach as many folks as we can without having to send them over the hill and then navigate all of those cumbersome processes that entails. That also entails working closely with the other healthcare partners that we're lucky to have in that community. And so the work that we've done with Lauren, what's fun is Lauren and I have worked together for a number of years in different capacities to really be effective in serving that community. And so I'm not a PowerPoint expert by any means, so bear with me on my very busy one slide. But we have, I broke our process into a few different buckets, but as you'll see on the right, we have a number of programs that we have listed, and I am embarrassed to say I left out one very important new one, which is our hospital transformation program. So in addition to all of these clinic-based processes that we also have our HTP program that we have online, and then various other programs that don't fall within an insurance contract as well. So with that, we have, of course, our external data coming in. We have our own EMR data. We have our value-based contracts from various sources that provide us with data. And then we have our care management contract data that we bring in. From there, we do all the special things that I am not very savvy at describing at a very in the weeds level, but essentially, we use that data to understand our daily census. So who is coming through our doors, both at our hospitals and at our clinics. We have a system within our EMR, which is Meditech, which provides us with business analytics. It's really awesome to help us pull reports and analyze our data to understand the impact for strategic decision making. We utilize our data to build registries to address things like our population health and risk management, clinical quality measures, and our utilization data. We've talked a lot today about third next available or access. We certainly use our data to understand and automate as much as possible our access and understand where those gaps in care might be. And then, of course, as was discussed earlier on a panel, we still have our manual tracking. So unfortunately, with all this awesome work we're doing, we're still seeing that we do have some manual spreadsheet management that we're doing on top of all of this fantastic data management. What I want to highlight is that it certainly takes humans to do all of this awesome work, and so luckily our organization has been very committed to investing in that sort of resource that's required, and so we have folks behind the scenes partnering with Contexture to do some data validation and some analysis of helping us understand what stage of a measure something is in and what sort of attention or activity is needed to improve performance. And then we have our response to our data. So as was said before, it's one thing to get all the data in one place, it's another to actually do something with it, which even though it continues to feel like we're in an infancy stage, we're doing quite a bit with our data, which is awesome. So one is developing our measure dashboards. In doing that, that's really where that partnership with Contexture has come in handy, where of course we're initiating the build of a measure, starting with, do we even have the right definition for the measure? It's amazing how not only is it very easy to get the definition of a measure incorrect, but there are also different definitions depending on who the payer is. So making sure that we have the definition understood and that we've built it correctly, then testing it and retesting it to make sure that we know that it's built and every step of the process is pulling correctly. Then of course there's the validation of the measure once we know for sure that it's built correctly, and so we have a whole team that works on that validation piece. From there, we move into monitoring it to ensure that it continues to work and hasn't broken. And only if we feel like all of those steps have taken place and we're confident in what the data says, then would we move it into a PDSA phase, which is where it becomes more front-facing for our team, where we're bringing the data to our providers and staff saying, this is how we're performing, what do we want to do to improve? And so we feel really confident, and it's probably through trial and error, that we've learned that we have to go through these first phases before we present the data to our team, because if we present data that's broken or untrustworthy, we're going to lose an audience and we're going to lose engagement in improving performance before we've even gotten started. And then hopefully from there we perform well. We also respond to our data through our care management activities and doing some targeted population health outreach. We do a ton of planned care activities, so taking the data that we have to help inform who's about to come through our door so that we can make the most of our team-based care visit and capture that. We use this data to have targeted campaigns, which we'll push out through our patient portal or our texting campaigns that we run. And then of course, as I said before, PDSA, which is our bread and butter. So I think that's a great high-level nutshell. I think all of this is possible because we have a leadership team that's really dedicated to quality as a pillar of our strategy, and so we've been successful in that partnership. Thank you.
Rich, do you want to talk about Champions Family Medical?
Sure. Again, my name is Rich Lane. I'm the practice manager at Champions Family Medical in Pueblo, Colorado. How many people know where Pueblo is? 6 miles south of Pinion. So in case you ever get lost. Anyway, in my professional career, I've been involved in a lot of different things, and in 2010, we opened up the clinic. I also have an after-hours career, which is, I've been a high school football coach for 28 years. And as Lauren said, we have a staff of 11. There's 11 football players on the field at any one time, so there's no coincidence. So team is a big deal for me, and I want to highlight our team. And along the way of the 28 years of high school coaching, I was able to be the offensive coordinator, and we won back-to-back state championships at Pueblo East. So. And then I retired, and they won a third one 3 years in a row, so they kind of were able to carry on. But the team's important for me. So the high level, if you look at it, we started with our ACO with UC Health back in October of 2017. And we've got Don and Kate back there, if you guys want to raise your hand, who are part of the C3 team at UC Health. And when they approached us back in 2017, Dr. Austin Bailey and Paul Staley, they said, hey, we want you to join our ACO. I said, what's an ACO? Leave me alone. We're not interested. Why are you picking on me? We're a small clinic. There's 2 providers. Hey, we can make you money. Okay, let's talk, right? So we went through the whole thing of, the commercial Medicare Advantage programs that we're in contracts with. We meet monthly with the team from C3. They provide awesome data. They give us the information we need. They challenge us to, do better on our measures. They also give us a lot of tools that help us along the way. And, oh, by the way, they're paying us to do this. And it's like, oh, this is great. For a small clinic, we could never engage in any of this on our own, especially with the risk-based programs. I'm not going to sign up for a risk for our 2 providers. We want everything that's upside. We don't want any downside, right? We got to be smart. But they're taking the downside for us on some of the programs. But because we're a part of their group, we're able to leverage off of their resources and the entire group and benefit from it. Some key things that we've done, I talk about team and coaches. C3 is one of our coaches, behind the scenes. We have 11 people in the 4 walls. We have a lot of coaches outside, coaches and coordinators. I'll call them my coaches and coordinators from C3. They have a group of nurses that do care coordination for us. Anytime any of our patients that are in these contracts go to the hospital and get admitted or go to the emergency room, their nurses follow up with them within 24 hours and send me a detailed report that we can then give to our providers in addition to the reports we're getting from the hospital. So talk about an awesome team, right? We could never afford that. But they do that for us. They give us the reports. And the great thing about it is when we talk about all these high-level programs, how's the government going to get involved? How are we going to coordinate health information? We sign a business associate agreement. They get right into our database. When the nurse calls, they know exactly our patient. They're talking straight from our EMR to that patient about everything that they know based on what's in our EMR. So what a great collaboration. Another thing that we did a big project on was the generic versus name brand dispensing of prescriptions. And I think it was in 2020, Don, maybe 2021. If we as an entire group reduced our name brand to generic dispensing by 1%, we saved the group over $1 million in prescription costs. And we were able to change the needle in our clinic by 8% within 5 weeks just because of the data that they gave us. Otherwise, we would have just kept going on with name brand and everybody was happy, or at least insurance companies were happy. And then the other big transformation we're going to make is from going from MIPS reporting to MSSP with UC Health in 2023. So we're excited about that. So Don and Kate, thank you for your team and all your support. The next group I want to recognize is Beacon Health. And Nate, you're back there somewhere. Raise your hand. Nate Kohler back there. We started with them in June of 2018, and they're our RA for Region 4. And again, it's one of those things when they came to us, hey, we can provide you with PMPM money per month on all your Medicaid patients. Here's what we'll do for you. Nate is our practice transformation coach, and he comes out with incentives to say, hey, do this, this, and this, and we'll pay you X number of dollars. And it's not only to earn the dollars, but it's to change the way we do business in our clinic with our patient, with the patient flow, and with the staff. And they also provide care coordination through another entity on the emergency room and inpatient hospital visits for our Medicaid patients. And we get those reports back within 48 hours. They don't have access to our database, but they have access to the Medicaid database that has everything about that patient that they would need. Nate is involved in the monthly meetings that we have with, and I'll talk about Jolene and Correo and Contexture later, but important that we get to meet with Nate as well as what we do with UC Health every month to see where do we stand and how are we doing and how can we do better. So we have monthly meetings, quarterly meetings, and we have end-of-year wrap-up. We started with the APM1 program with Medicaid in January of 2020. With all of the reporting that's required, we could never do it on our own. And thank God we got Correo at the time to help us out. And now, I'll jump to the next one. We started with the Innovation Support Project, 4 months later in April 2020. And we have a great manager, coach, leader in Jolene. Jolene, raise your hand. She should get an HIE Service and Excellence Award because she is unbelievable. I mean, she challenges us every month and even in emails during the week. Hey, Rich, we need this, we need this. Well, we submitted our data for APM1 for 2021, and I was discouraged when we got the results back from the state. Even though we achieved and we're above the goal, it just didn't sit right. So I sent Jolene the report, said, here it is. She goes, Rich, you need to refute this, and here's why. She gave me all the reasons why I sent the letter to the state. You're right, we found a mistake. And I said, no, Jolene found the mistake. We need credit for it. So we went from like, what was it, Jolene, 230 points to 270 just because she caught it. But that's the level of detail that she provides to us on our team. And again, she's a coach, she's a coordinator, she's a leader. We couldn't afford that as a small practice. But when I look at the whole team, we all have equal parts in this, and every spoke is important. And if one spoke breaks, and it's usually me, they got to pick me up and mend it, and let's keep going. So Jolene, thank you for all the stuff that you do on there. That's not even the tip of the iceberg, but Lauren, are you her boss? Give her an award. And then we went to APM 2 in the first of this year in January 2022, and Allison's in the back. Allison, wave your hand. We've gone way back, and she's been tremendous in helping us get involved in these things. And she reminded me that I was the first one, I think, to jump in full speed in APM 2. And again, Dr. Bailey and Paul Staley taught me in 2017, if somebody's coming to you and giving you money, don't turn them down. And so the state has been very gracious in this program, and it's benefited us tremendous. We found some mistakes in their payouts. We've identified it, they've identified it, we're getting it corrected, but it's been a blessing to us in our clinic. And again, thanks for letting me come up here and share the high level details of where we're going in our clinic.
Thanks, Rich. Dr. Mahaso.
All right, hi everybody. So again, I'm with Vista Health Center. We are in Parker, Colorado, and we are a residency clinic so that we have residents who started graduate medical school, and now they're doing their 3-year internal medicine residency. So they work at Skyridge Hospital, they work at Aurora South, and they work at Presbyterian St. Luke's downtown in Denver. So what we do, we have 52 internal medicine residents. We have 3 which are osteopathic. That's people who are doing family medicine residency, finished that program, and now doing 1 more year for manipulation of your back, your neck. So it's a specialized residency for 1 year. And then within our clinic, we also have a podiatrist, Dr. Weiss is there, we have a nephrologist, Dr. Schlesinger is there, and we have Dr. Giva for behavioral health, a psychologist. So we have a lot of doctors in the practice, and we're not just primary care. So we have to be careful when we're doing our reporting that we're capturing just primary care, otherwise I get so upset, I email them, you guys added somebody else on my list, you know, so it's very important to kind of capture the right people for the population, which Corio is really good, and Terry said, Tiffany, you're right, we'll redo the denominator, because I get really worked up on those denominators. So as far as efforts, we're part of Rocky Vista University, so we have a medical school, a PA program, so the university by law, we have to have 10% of organic revenue from outside of student loans. So we have student loans 90%, but we have to have organic revenue, which is where the clinic comes in, where my staff and myself have to garner revenue. So we use a lot of programs such as Cardiac Care Partners, Practice Health, Cardiac Access to all help with that number, the 10% of the revenue to be from organic clinic money, not all from student loans, basically. So Cardiac Care Partners is an ACO here in Colorado that they do value-based care contracts. We focus on diabetic exams, we do hypertension, colon screens, mammograms, anything that's kind of preventative care for our patients in the clinic. We have Practice Health as well, which is a fee-based service, essentially, and we also use them to track reporting, similar kind of concept, but a different outlook, I guess. Cardiac Access is what we use for our Medicaid patients. So we use them for, again, screening for Medicaid patients in Colorado who don't have a primary care doctor within Parker, Kiowa, South Denver, pretty much. We're kind of the go-to people for that. So we have about 2,000 Medicaid patients in our clinic. So we really want to serve the community and get their needs taken care of. We did an ISP with Corio and Terry last year as well, which kind of make things better for the practice. We capture all the quality metrics better, and so determinants, all the things we're all kind of working on this year. Those are our main components for our revenue piece with these programs. Okay, so how do we track all this stuff, right? So when I came on board, I was very overwhelmed because we have different companies, if you will, like, you know, ACOs that we're utilizing, and they all want different things for their year. Like, okay, we're doing colon screens, or we're doing diabetic A1Cs, whatever it is. So it's very overwhelming initially, like how am I track all this stuff? And so we had of course, Athena Health, which is our EMR system, to kind of capture that stuff, of course. But Korea helped kind of reconcile that for us, so, where we can see it in Athena, but then Korea say, actually, you guys had this patient or these people that were not, recorded properly, maybe in Athena, or they missed it, kind of thing. So we're able to reconcile both Athena records and Korea Contexture records as well. Additionally, we can use certain things like hospital TOC. So a patient was in the hospital at Skyridge, they'd been discharged. So Allie in the back over there is amazing. Hi, Allie. Every single morning, I get an email from Allie without fail. Who was in the ER, who was discharged, who's been inpatient. So we can track those patients and can follow up for them and say, hey, you were discharged at Skyridge yesterday. How are you feeling? How are you doing? We want to see you at the clinic within the next 14 days, right? So my staff calls the patient within 2 business days to get them on the schedule, and then our residents see the patient. So we use Athena and, of course, the emails from Allie to kind of get those through to our patients for care. Additionally, we have navigators. It's a whole support team, like he's saying. It's like a whole team of people who just want you to do well. They really have your best interest at heart. They really want to, hey guys, you're doing great in this area, but you can improve on your MAs can do blood pressures twice. Like last week, or a month ago, Allie emailed me, hey Tiff, your MAs are not always capturing the second blood pressure. I'm like, yes, they do. Like, oh, but then it's not in the Athena system, right? So they want to make us do better, so we get more money, the patient's being taken care of, and we're capturing, those high blood pressures. So those navigators, the care coordinators, all play a role in our staff. They come to visit us. Once a month, we have meetings with them. So it's really vested in the wellness of the clinic, not just for monetary gain. It's like, hey, your patients need to do better, or they're in the ER, like it's frequent flyers to ER, or they're there why are they there every single Friday night? Why are they there every other, for diabetic, uncontrolled diabetes? So they really kind of monitor all those metrics for us, and every month I have a report showing that, hey, this month you had 20 people who went to ER, or 100 people have not gotten the A1Cs done, or whatever the case is. They really monitor every kind of quality metric for us, so we can call those patients, and if we can't do it, Allie and her team will call them for us. They'll say, hey guys, we'll call all your colon screen people, all your mammograms, whatever it is. So it's really, really hands-on, so that we do well with our metrics for our payment, stuff like that. Like I put on here, we have an individual like Allie and Terry and Joe English. They all work so well with our practice. I meet them once a month, so that we do well. And they want to say, hey, if it's too much, let us know. If it's too little, they really are involved. They're not a nuisance to myself or the staff. They just want to make sure we're doing well to get the best results. So, yeah.
Thank you. So moving into our panel discussion, the first question I have for our panel is, how does the Health Information Exchange Contexture support you in the various programs and in achieving that quintuple aim?
Do you want me to start?
Sure.
Okay, so I had to have notes because there's so much that we've done over the years to address our now quintuple aim, which I agree with Lauren. It's awesome to see that model evolve as we try to do a better job of addressing the whole person in healthcare. So certainly they are incredibly robust. I'm so glad you gave a shout out to Jolene, because I want to echo everything you just said with regard to her coaching and consultation around all of the work that we do to perform well as it relates to our alternative payment model with Medicaid, and of course our MIPS reporting with Medicare. So our team works with Jolene pretty regularly to help in those steps that I described earlier around building our measures, validating them, helping to monitor, giving us feedback on where we might have something broken within the process, and then helping guide any PDSA work that we need to do to improve our performance. Jolene and in the past Lauren have been instrumental in helping us with cost analysis, so being able to get our QPP data and really dig in at a very in the weeds level to understand what's showing up in a cost report, where our high dollar procedures are affecting us, and then not only giving us the data, but then also guiding us through strategic discussion. And so, if something is popping up where we're higher than our peers in a certain area, what are some things that they have seen that would help us reduce our cost or improve our performance in that space as well? Then I would say, and one of the things that I was so incredibly impressed with, and we're now moving into phase 2, is they did an intensive deep dive into our HCC coding documentation, where they pulled a number of charts, and because they have some unique expertise in this area, in addition to all the other things that you saw, they gave us an audit of our documentation and trained all of our providers on improving our HCC coding to better meet those expectations, kind of similar to what you were describing before, where we knew we were doing it, but it didn't necessarily translate into the documentation itself. So I would say, you know, with all of those pieces, I would be able to link those to each of the 5 elements of the quintuple aim. Obviously, you know, building the system correctly in theory should allow us to achieve improved outcomes for our patients and reduced cost as described. But I think in addition to those obvious components, you know, knowing that our data is solid is going to improve team engagement and team satisfaction. Having our teams click 900 buttons is going to create fatigue, but if they know that the result is going to lead to less work down the road as well as improved outcomes and reduced costs, and we can show them how those things all link up, which we've been able to do through the help of Jolene and Contexture, it leads to that team satisfaction. Having patients feel confident and trust in us when they walk through the door because we have solid data and patient information readily available to guide the visit, I think is incredible. And then we're starting to move more into the space of addressing the social determinants of health through capturing in the data. We'd had the workflows in place for a while, but we didn't have a great way of translating that into data capture. And so that, of course, is where we're headed next with HTP and some of the work with our APM. And so that's, of course, going to address and hopefully improve telling our story of equity and feeling confident that we know if there are any communities that are having poorer outcomes, we can see that and improve that. And then I think at a very high level, where the HIE has been incredibly supportive of us has been at making some pretty specific strategic decisions about programs that we engage in or not. So certainly Jolene partnering with our APM coach, Tina, to help us make some strategic decisions about measures that we choose or workflows that we need to design, and the way our team has worked with those 2 entities together has been incredible. And then they've also been helpful at helping us decide not to participate in certain programs. So because so many of these programs do have some pretty significant risk involved, they've also been instrumental at helping do a deep dive into our data to say, you know, this would be an area you may want to hold off on for a year and make some improvement in this space and then consider it again. And I think so often we feel like we have to jump in onto everything and then figure it out as we're going. Sometimes it makes sense to slow down and make a, you know, decide if the risk is worth it or if we want to wait and put some effort. And so I would say Contexture and Jolene and Lauren specifically have helped us navigate some of that as well.
And I would say, I think they've provided us support with training guides, if that makes sense. So what they do is they'll create a screen grab. So let's say we're doing a, I don't know, blood pressure. We have to either tell us, click here in Athena, click here, and then it'll actually register because we were doing it, we thought, but we weren't capturing every little piece. So they made me screen grabs for my residents. I have 50 residents in the clinic. They're not here every month, so they're here every other month. So what I do, I create like a PowerPoint, I email them, hey guys, this month we're focusing on, I don't know, obesity education, for example. And I have them, hey, when you discuss, weight loss, if they're out of range for their BMI, you have to click cancel patient here, click this little button here, it'll bring this new thing up, and that will capture the quality metric for us. So having those screen grabs that we had from Terry is very useful for me and all of my residents to realize, okay, we're discussing, weight, but we're not really capturing the right part in Athena. So that was very helpful, I think, for us to capture those metrics.
I'll echo on what Audrey said as well with Jolene. We have monthly meetings, and Jolene involves Nate from Beacon Health and as well as a representative from the Pueblo County Health Department. So it's a whole team, that we can all meet together at once and what are the best practices? How are we doing, quarter to date compared to our goal, and how are we doing quarter to date compared to the previous year? So we get a lot of great reports, a lot of great input. Jolene has had experience in eClinicalWorks, which is our EMR. So she's able to help me with some tips on, hey, make sure you do this, this, and this. And sometimes, yes, we have to check a lot of boxes, but we miss a box and you don't get the score. But just those reminders and the monthly coaching, but it's not just monthly. Jolene and Nate and the folks from UC Health, they're not afraid to send emails, every day or every week if they have to. And that's important for us because we know they're looking out for our best interest, and it helps us feel like we're doing the right thing. And again, we're a small practice, so we don't have resources that we normally would have if we're in a bigger group, but we do have a bigger group and we have a lot of resources. It's how much can we absorb and implement. And like Audrey said, you can't take everything on every time. So I've had to tell Nate a couple times I can't go to that meeting, but maybe next month. But at least it's out there and we have an opportunity to participate.
Thank you. What would you say the top 1 or 2 challenges in implementing value-based contracts are, and how can Contexture help you through those challenges?
You want me to start?
Sure.
The biggest challenge is how do you achieve it across all of your payers, right? When we went from ICD 9 to ICD 10, you went from 8,000 codes to 72,000 codes. Now we've done the same thing with what are the requirements that every payer wants. And so UC Health and Jolene and Nate have taught me, attack the top 80%. If they're saying you got to be below 8% for diabetes in control, then strive to be below 8%. If one payer says you got to be below 9%, if you hit the goal on 8, you hit it on 9. So focus on where your biggest impact is. So that would be number 1 is how do you obtain and achieve continuity across all the payers. I wish we would have a more common system, but we don't. And the other thing for us, and again, I don't think I'd do it alone, is, and UC Health takes it on, is the downside risk contracts. We couldn't afford to put money in reserve to pay back if we messed up, right? So I see that as a challenge is for what they have to do. And they also tell us, hey, we're going to bring this to the table, but this may not be for you, or it may not be for us as a whole group. So, those are the 2 things that I look at as the 2 challenges.
I guess I can go. Mine's a bit unique. Because we are one tax ID with primary care, then we have OMM, podiatry, nephrology, et cetera. At times, we don't get all of our people in the denominator situation, which is very frustrating for me. But Terry does go back and, each person, they had a mammogram. Did we get it connected through your system? So she goes through each person literally with me. So I'm like, nope, that seems too low of a percentage for some reason. Because they're adding sometimes the OMM or the non-primary care people in our denominator. So it does frustrate me, but it's not their fault either, right? Because we're all in the same tax ID number. So we can't really extrapolate, okay, these people adjust for feet. Although we want to do that. I don't know how to, that's my biggest frustration, honestly. I don't know how to fix that, but it happens because we have 30% of our people are not, internal medicine providers, but with this, we share the same tax ID number. So that is my biggest challenge with the value-based contracts because we get some people who are not supposed to be in that denominator. But to support you guys, I thought Terry does go literally and check, oh, you're right, that was OMM. Oh, you're right, that was just for podiatry. So they kind of grab random people at times, but she does remove them from the denominator for me. And so I'll email so-and-so to kind of investigate further for you guys. So that's been the issue that we're trying to still resolve, I think, currently. So
I think in addition to both what you both shared, I would see a couple of the biggest challenges we see that probably go hand in hand are change management and capacity. And I'm sure we're all feeling that same thing, so much change fatigue as it relates to where we're headed in healthcare and payment reform, but we're not there. So we have to keep doing what we're doing while also doing this new thing, and we haven't fully jumped into the canoe, so we're straddling the dock in the canoe, and it's really choppy water. And so helping our teams build capacity for all of these additional pieces while still having to meet fee-for-service expectations, I would say, is really, really challenging. I think that, I said it before, but I will say it again, having all of the support to ensure that our data is working and working well and is trustworthy, I think helps mitigate some of that, because again, if we're expecting our teams to take on all of these different pieces and engage and buy in and believe that this is a good thing to be doing, we have to know that what we are reporting on not only to our payers and our contracts, but also internally as it relates to, say, provider variable pay. We have to know that the data and the reports are solid, and that we not only know that they're solid, but they're going to result in good patient outcomes, which is why everybody came to the table to begin with. And so I don't think that it's where we want to be, of course, because we haven't yet jumped fully into value-based payment models yet, but I feel like the support we're receiving is helping us build that infrastructure.
Thank you. So where do we anticipate, so we talked in the last session, where is HIE going in the future? Where are value-based payments going, and how can Contexture show up for you all to be able to meet those future needs of these value-based contracts?
Sure, I'll go first in this one. I think the changes, is just resources and demand is what my concern may be. I think with so many residents in a clinic, for example, to teach everybody, and on the same page, that, hey, for all of these metrics, this is how we do this, right? I think that's a big demand. When people go to medical school, they're not taught any of these things at all. You just kind of how to treat a patient, here's a drug, here's the side effects. There's none of this kind of training as far as residents and new providers. So having, hey, in the future, we've integrated that's part of education for residents and medical students that, hey, when you go start practicing, there are value-based contracts and you have to measure certain things. I think that's kind of looking ahead. How can we teach those in the future providers? That'll be helpful, I think. And having the resources to teach the ever-changing, 3 years and you're gone, 3 years, you're gone. So having the resources to teach these people so they know when they come into the workforce, hey, I'm familiar with the value-based contracts and how to, garner extra revenue for my practice. So I think that's something in the future we need to anticipate training upcoming providers. And I think that honestly, just having more training will be helpful in education resources for young providers in the future.
Want to go?
Sure. I think that we will probably see a continued increase in a focus on cost. I know that in the beginning there was quite a bit of focus on quality, and I think that that's important for patient outcomes, obviously, but I think that from external forces coming inward, we'll see continued need to demonstrate how we're reducing cost and how what we're doing is leading to those outcomes as well.
I think our biggest challenge will be to continue to have the teamwork from UC Health, Jolene at Contexture, Nate at Beacon Health, because we can't do it alone. And I know they reach many different groups, the care coordination, just the follow-up and the expertise. There's no way I or anybody on our staff could ever stay up to speed to what they give us every day, every month. So I think there's going to have to be duplicates of those people out there to help us and help other organizations to continue to be able to accomplish this, because it's not easy. It's a drastic change. And obviously at the end of the day, revenue is what counts, right, to keep the door open. But the quality of care is so important that we can't lose that face-to-face time with the patients. We need all the help we can get behind the scenes. And we greatly appreciate it from everybody that's involved.
Mm-hmm. So we are going to move to questions, but before we do that, I do want to just call out a really exciting opportunity that Contexture will be supporting in 2023, and that is the House Bill 22-1302, and it's the Primary Care and Behavioral Health Statewide Integration Grant Program. And there will be an RFP for practices starting in January of 2023. And this will be for practices to receive grants, and through that you'll receive practice transformation support, and one of your options will be Contexture as one of those practice transformation organizations. So we're really excited for that opportunity, but that will be open to primary care, internal medicine, I believe pediatrics, and OBGYN clinics. So really exciting opportunity coming in the future where Contexture can support you. And with that, I will open it up for questions.
Never one to shy away. So many moons ago, I used to work on the ACC Payment Reform Subcommittee with HICPUF, and we had months and months of conversations about how to start to implement measures for performance-based payments. when we got to the end of our conversation, we were left with a stack of claims-based data. I'd be really curious to hear from you guys, 10 years later, the impact or the value that you found from a clinician's perspective or a patient's perspective or a practice perspective. What is the value of being able to use actual clinical data for value-based payments rather than being restricted to claims-based information?
I think the biggest challenge we have is, you go from coding, here's the visit, 99213, and now you have, 20 reporting codes that go with it. What we don't know is what hits the payer. We only know what we get paid. It's too late when you find out what codes did or didn't make it to them to meet your, clinical quality data. So, I guess the short answer would be, I don't know if there is an answer, to be honest with you, because the claims lag so far behind from when you actually get the reports. But then at the same time, we know what we're doing in our EMR, that we can at least, the clinicians know that we've at least reported and documented, what we should from a clinical quality perspective.
I think to piggyback off of that, I mentioned earlier the work that Jolene has helped us with HCC coding, auditing. I think that's been an awesome way to make sure we're doing what we need to do before the claim goes out, so that when the claim comes back, we feel confident that it represents the population that we're serving. What we learned through the process is that, we feel like, given the geography and the social determinant challenges that our community faces, that we were probably serving a challenging medical population, and yet it didn't necessarily reflect that in the claims across the board. And so, with the support that we received, we are now better able to tell our story in a more accurate way, if you will. And so, I think that was a really good way to see in real time what would be showing up 6 months, 9 months later, and feel confident in that process. Because I would agree, I think sometimes there's a challenge that we have and a frustration we have by just relying solely on the claims data to help drive our decision making. What I would say is one of the things that we have been able to use the PBIP information around has been thinking a little bit more about workflow in the moment and helping to guide some of our pre-visit planning a little bit more accurately and timely as it relates to maybe our huddles or who's coming in. So I think that's given our team a lot of satisfaction to more accurately and timely know who they're serving. Another interesting area that we've been able to use our PBIP information around has been looking at our cost. And so by doing some of that cost analysis, we were able to see how much are our patients needing out of primary care versus specialty versus an ED versus going out of our valley, in fact, and how do we help target those interactions more specifically to bring folks back into primary care. So I would say that would be how we have started to utilize both sets of data, maybe congruously, instead of just relying on claims, which we've done in the past.
Same answer, I think. I think we use the report now, like it's almost retrospectively looking at it and say, okay, now we know in the future for future claims, we've used these codes. They're paid out better, and it captures the metric as well. So in real time, yes, you have to wait a bit longer, but then when you do get the codes, now you know for the next person comes in what codes to utilize. That's how we've done it. So.
Well, if you could all give a round of applause for our panel, we were very happy to share with you today.